Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of July 2008. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosures. We'll begin with this month's clinical case conference, in which Sharman Ghaznavi and colleagues discuss the resumption of clozapine treatment after development of neutropenia. We'll follow that with a report by David Sulzer and colleagues on clinical symptoms in the CATIE effectiveness trial for Alzheimer's disease. Then we'll turn to depression in late life, beginning with decision trees for treating depression in elderly patients. Another study examined state-related and disease-related alterations in neural responses to affective and executive challenges. Dr. George Alexopoulos relates both of these articles in his editorial titled Personalizing the Care of Geriatric Depression. Next, we'll highlight a report by Kathleen Carroll and colleagues on the treatment of addiction with computer-assisted cognitive behavioral therapy. We'll conclude with a study by Christian Griot and colleagues on a possible physiologic marker of panic disorder, followed by an editorial by Walton Roth about translational research on panic disorder. We'll begin with the clinical case conference by Sharman Ghaznavi and colleagues, titled Re-Challenging with Clozapine Following Neutropenia, Treatment Options for Refractory Schizophrenia. Polypharmacy may have contributed to this case of neutropenia. For 12 years, the patient had been taking 750 milligrams of clozapine and 1,500 milligrams of valproic acid each day. Then he began taking donepezil to improve cognitive functioning. 1 month later, his absolute neutrophil count was 1,600. The treatment provider discontinued both clozapine and donepezil. The patient continued to take valproic acid, and risperidone was added. A week later, his neutrophil count was much higher, and clozapine was reintroduced. The dose was gradually increased to 500 milligrams per day. 6 weeks later, his absolute neutrophil count was 900, and the clozapine was again discontinued. The patient was subsequently treated with risperidone, olanzapine, and valproic acid. The patient felt that he had a better quality of life and better cognitive function when he was taking clozapine. Therefore, the valproic acid and olanzapine were discontinued over 1 week in the inpatient setting. Lithium carbonate was then introduced at a dose of 300 milligrams per day. 10 days later, the patient's neutrophil count was 4,900. Clozapine was restarted 3 days later at an initial dose of 12.5 milligrams per day, which was gradually increased to 300 milligrams while risperidone was tapered. At the time of discharge, the patient's absolute neutrophil count was over 5,000. In the following 6 months, his blood counts remained in the healthy range. His symptoms also showed marked improvement. The development of neutropenia after 12 years of clozapine is atypical. The author found only 4 case reports of neutropenia or agranulocytosis at 5 or more years of treatment. In 3 of these 4 cases, the patients were taking additional psychotropic medications that carry a risk for blood dyscrasia: valproic acid, haloperidol, or risperidone. This raises the question of whether the neutropenia or agranulocytosis in those cases was the result of a synergistic effect on hematopoiesis. When this patient first developed neutropenia, he was taking valproic acid for seizure prophylaxis. Unfortunately, the valproic acid carries a risk of neutropenia and has been shown to increase serum clozapine levels when used adjunctively. The decision to discontinue valproic acid came after a careful review of the literature about clozapine-induced seizures. For example, the risk has been shown to be dose-related, and this patient was taking 350 milligrams of clozapine daily upon discharge, putting him at a low risk. Furthermore, the use of anticonvulsants in patients taking clozapine is recommended for those who have had documented seizures as a form of secondary prophylaxis. In his case, the valproic acid had apparently been introduced as a primary prophylaxis, since he had no documented seizures. Another important consideration is that when the patient first developed neutropenia, it was 1 month after he began taking donepezil. Donepezil has been reported to cause a number of hematological side effects, but it has not been shown to cause neutropenia. However, it is metabolized by 2 of the same cytochrome P450 isozymes that are responsible for the metabolism of clozapine. Risperidone also carries a risk of neutropenia in agranulocytosis, and it has been shown to increase serum clozapine levels. Therefore, the combination of clozapine and risperidone at the time of the first re-challenge may have increased the risk for neutropenia. There have been 3 case reports of neutropenia or agranulocytosis in patients treated with clozapine and risperidone. These include 2 of the 3 cases of late-onset neutropenia. In one of the late-onset cases involving clozapine and risperidone, the neutropenia resolved when the risperidone was discontinued. Co-administering lithium with clozapine has met with some success. However, there is some risk of adverse neurologic effects. The risk is either transient or minimal, and it is best approached with careful observation when lithium is initiated and with vigilant monitoring of blood counts throughout treatment. Another means of increasing the white cell count in patients taking clozapine has been proposed in the last decade. This approach involves granulocyte colony stimulating factor. Its most common side effect is bone pain, and there is concern about a possible causal relationship between the long-term use of GCSF and the development of acute myeloid leukemia. Additionally, this treatment is quite costly and invasive, as it requires daily or weekly subcutaneous injections. The authors conclude that this case highlights the need for rational pharmacotherapy in treating patients with long-standing psychotic illness, whose clinical pictures are often complicated by multiple pharmacologic interventions, and for whom we have limited, well-validated treatments. Now we'll present the research article by David Sulzer and colleagues. Clinical symptom responses to atypical antipsychotic medications in Alzheimer's disease. Phase 1 outcomes from the CATIE-AD effectiveness trial. The trial included more than 400 patients with Alzheimer's disease who had lived at home or in assisted living facilities. Each patient also had delusions, hallucinations, agitation, or aggression nearly every day over the previous week or intermittently over 4 weeks. They were randomly assigned to masked treatment with placebo or one of 3 antipsychotic medications for up to 36 weeks. The 3 antipsychotics were olanzapine, quetiapine, and risperidone. The dose could be adjusted by the treating physician, who could also discontinue the initial medication after the first 2 weeks of treatment. 2 sets of analyses were conducted. One included all of the patients who took at least 1 dose of medication, and it used the last observation carried forward method as the final measurement. The other analyses included the 150 patients who continued the initial treatment for at least 12 weeks. In the analysis of symptoms at the last observation, improvements were seen in both global as well as specific symptoms. Beneficial effects of olanzapine and risperidone were apparent in the total score on the neuropsychiatric inventory. Risperidone also had a significant positive effect on the clinical global impression of change, which is completed by clinicians. Specific symptoms were tracked with the Brief Psychiatric Rating Scale, or BPRS. Olanzapine and risperidone produced significantly greater improvement than placebo in the BPRS factor representing hostility, suspiciousness, and uncooperativeness. Risperidone was also associated with a decrease in ratings on the psychosis factor. On the other hand, olanzapine had a worse effect than placebo on the BPRS factor for withdrawn depression. For the patients who completed 12 weeks of treatment, the proportions of patients who were rated by clinicians as much or very much improved were 40% for placebo, 45% for olanzapine, 52% for quetiapine, and 61% for risperidone. These proportions were not significantly different, however. The symptom changes in the patients who completed 12 weeks of treatment generally followed those for the analyses using the last observation carried forward. In addition, the patients taking quetiapine had greater improvement on the BPRS agitation factor than those taking placebo. However, the antipsychotic medications did not improve cognition, functional skills, caregiving needs, or quality of life. The patients taking olanzapine actually had a greater decline in activities of daily living than those who took placebo. The authors point out several limitations of these findings. The improved symptom ratings frequently occurred very close to the time when the clinician was changing the treatment. Often these changes were due to judgments that the treatment did not have sufficient efficacy. It is possible that the clinicians were seeking even greater improvement or were balancing benefits with other considerations, such as adverse effects. Also, the average improvement on the rating scales was limited and was not apparent for all symptoms. Anger, aggression, and paranoid ideas showed the greatest improvement. This preferential response supports an individualized approach in clinical practice. Now we'll shift to depression among the elderly. Carmen Andreescu and colleagues present empirically derived decision trees for the treatment of late-life depression. Their aim was to develop a clinically useful algorithm to allow clinicians to predict which patients are likely to respond to treatment. They pooled data from 3 previous studies, including nearly 500 patients. Scores on the Hamilton Depression Rating Scale were available over 12 weeks of treatment. There were 2 criteria for a response: a decrease of at least 50% in the Hamilton Depression Score, plus a final score of 10 or less. First, a univariate logistic regression was performed on the demographic and clinical variables to identify potential predictors of response to treatment. Signal detection was used to create a hierarchy of these predictors. Signal detection methods are useful when predictors are likely to be highly collinear and when there are interactions between independent variables. In this case, the signal was the binary outcome, response versus non-response at 12 weeks. Signal detection identifies predictors with a stopping rule of p less than 0.05. The highest predicting variable is used to divide the sample into 2 subsamples, and the next predicting variable divides the higher risk subsample. The process continues until the lowest risk variable stops at p less than 0.05. 2 decision trees were constructed by altering the sensitivity thresholds for the proposed predictors. The first model was designed to minimize false predictions of future response. This was considered the aggressive treatment approach and would be used when it's particularly undesirable to have a long treatment trial that is eventually unsuccessful. In this model, the significant predictors of treatment response at 12 weeks were symptom improvement at 4 weeks, lower baseline anxiety, and older age at onset. The second model was designed to minimize false predictions of future non-response. This was considered the conservative treatment approach and might be followed when it is particularly undesirable to conclude prematurely and incorrectly that a specific treatment is ineffective. The significant predictors of 12-week treatment response in this model were early symptom improvement, baseline anxiety level, baseline sleep disturbance, and for a minority of patients, the adequacy of previous antidepressant treatment was also a predictor. The models emphasize the use of a standard measurement such as the Hamilton scale to monitor treatment response. In a managed care environment, it is difficult to use time-consuming questionnaires routinely. However, using the Hamilton scale or a self-rating at baseline and week 4 could ultimately save time and effort by helping clinicians tailor the treatment of late-life depression. In our second article on late-life depression, Li Hong Wang and colleagues report on regional brain dysfunction. They studied depressive state and disease-related alterations in neural responses to affective and executive challenges in geriatric depression. Although functional brain imaging of younger depressed patients has shown several regional abnormalities associated with cognition and emotion, similar studies of elderly depressed patients are scarce. 3 elderly groups were compared: 12 patients with current depression, 15 formerly depressed patients, and 20 healthy subjects. They were given an emotional oddball task, a cognitive test that required both executive and emotional processing. It contained 4 types of pictures. The standard stimuli were scrambled pictures. The attentional targets were circles, which were presented infrequently. The other 2 kinds of pictures were both distractors, but one type portrayed sadness and the other was emotionally neutral. The participants were asked to press a button when they saw a target stimulus. While the subjects performed this cognitive task, functional magnetic resonance imaging was used to measure brain activation and deactivation. It showed that when the acutely depressed patients were detecting targets, they had decreased activation in the right middle frontal gyrus. Also, during target detection, both the currently ill and the remitted patients demonstrated attenuated activation in the cingulate and inferior parietal areas. The similarity in the 2 groups with depression suggests that the alterations in these regions are related to the illness and not the depressed state itself. While attenuated activation of the anterior portion of the posterior cingulate might be disease-related, enhanced deactivation of the posterior portion was found only in the currently depressed patients. This difference suggests that the anterior and posterior portions of the posterior cingulate have distinct roles in geriatric depression. The significant differences among the 3 groups were mainly revealed during target detection, not during emotional processing. Therefore, executive dysfunction may be a prominent deficit in geriatric depression. These 2 articles are brought together by George Alexopoulos in his editorial, Personalizing the Care of Geriatric Depression. He points out that the various antidepressants have similar efficacy, but each agent helps a rather small number of depressed elderly patients. Identifying predictors of treatment response and matching treatments with patients could increase efficacy and preempt disability, worsening of medical morbidity, and cognitive decline. While personalized treatment is promising in the management of geriatric depression, its actual impact in clinical practice has yet to be tested. Important clinical questions include how long to maintain a given treatment and which patients are candidates for making a treatment change before enduring a protracted course of unsuccessful treatment. The article by Andreescu and colleagues addresses these questions. Unlike most earlier studies, this one focuses both on baseline variables and on change in depressive symptoms after treatment is underway. The authors found that response by the 4th week of treatment was a critical factor in determining the probability of response by 12 weeks. Of course, a strong treatment response by the 4th week suggests that the treatment should continue. However, if only a moderate response has occurred by that time, the clinician has to choose whether to continue the same treatment or do something different. The study provides valuable information for making these decisions. For example, moderate response by week 4 predicted full response by week 12 in 43% of all patients. However, patients who had low levels of anxiety at baseline had a 61% chance of a full response, whereas those with moderate or severe anxiety at baseline had a 39% chance of response. The probability of full response was even lower in patients who had experienced depressive episodes from early life. Another important step in personalizing treatment is to learn the type and nature of brain abnormalities occurring in patients with late-life depression. This knowledge can be informative in 2 ways. First, identifying persisting abnormalities during remission may indicate a high risk for relapse or persistent cognitive impairment. Second, the finding of brain abnormalities that predict poor outcomes of depression may initiate a search for their clinical correlates, which may then be used to personalize treatment. Wang and colleagues found that depressed elderly patients showed attenuated activation of the right middle frontal gyrus and a greater deactivation of the posterior part of the posterior cingulate relative to remitted patients and comparison subjects. The middle frontal gyrus exerts inhibitory control on emotional structures. The posterior cingulate is connected to the hippocampus and the posterior cortex, and it participates in memory retrieval and self-consciousness. Patients with Alzheimer's disease or mild memory impairment exhibit just the opposite deactivation effects on the posterior cingulate. Thus, the observations of Wang and colleagues may explain why mild cognitive dysfunction in depressed elderly patients often subsides after remission of depression and does not progress to dementia. Reduced activation of the supramarginal gyrus bilaterally, the left anterior cingulate, and the anterior part of the posterior cingulate was seen in both the depressed and remitted patients relative to the comparison subjects. These structures participate in executive function. The persistence of reduced activation here is consistent with the clinical observation that executive dysfunction in depressed elderly patients remains after remission of depression. Executive dysfunction and microstructural abnormalities in white matter connecting structures that subserve executive functions have been associated with poor or slow response of geriatric depression to antidepressant treatment. Taken together, these findings suggest that functional and structural abnormalities of networks relevant to executive dysfunction characterize a subgroup of depressed elderly patients who have poor outcomes. Bedside tests of these abnormalities are a possible next step toward a more biologically informed personalization of treatment. So far, the empirical basis for personalizing treatment principally consists of post-hoc analyses of unitary treatments. While this knowledge is necessary, it is insufficient for two reasons. First, depressed elderly persons face a bewildering constellation of health threats and social constraints. Therefore, they have many different contributors to poor treatment outcomes. Second, the skills available in various treatment settings and sectors can promote or inhibit treatment success. To benefit depressed elderly patients in the community, personalized care must employ comprehensive care algorithms targeting both modifiable predictors of poor outcomes and organizational barriers to care. Now let's turn to the report by Kathleen Carroll and colleagues on computer-assisted delivery of cognitive behavioral therapy for addiction. Cognitive behavioral therapy delivered by computer has been tested for smoking in several randomized trials with positive effects. Other computer-assisted treatments for problem drinking have also shown promise. In this trial, 77 individuals entering a community-based clinic were randomly assigned to 8 weeks of treatment as usual or treatment as usual plus computer-based cognitive behavioral therapy. The primary outcome measures were frequency of substance use and the number of positive urine samples. The participants had different types of substance dependence, but cocaine was the most common. The standard treatment consisted of weekly individual and group sessions of drug counseling. The patients who were assigned to the experimental condition were provided access to the computer program in a private room. A research associate guided them through their initial use of the program and was available to answer questions each time they used the program. The computer-based training in this study consisted of 6 modules. They covered substance use patterns, craving, refusing offers of drugs and alcohol, problem-solving skills, how to change thoughts about drugs and alcohol, and decision-making skills. After completion of the first module, the participants could access the modules in any order they preferred. They could also repeat them as many times as they wished. Each module is intended to require about 45 minutes. They were all structured in the same way. First, the key concept was introduced through a brief movie representing a typical situation. Next, the narrator explained the key skill covered in that module. Then the movie was repeated, this time with a different ending, as the same characters applied the skills to change the outcome of the situation so as to avoid substance use. Additional videotape vignettes were used to reinforce the skills taught. Next, there was an interactive assessment followed by a short vignette with an actor explaining how use of the skill had helped him or her avoid substance use and how each CBT principle could be applied to other problems. Finally, each model concluded with the narrator providing a review of the key points covered, followed by the characters demonstrating how they would complete the homework assignment based on the situation depicted in the movie. The participants were then given an identical assignment and a reminder sheet to take with them. The participants were assessed before treatment, twice a week during treatment, and at the 8-week termination point. The substance abuse calendar was administered weekly during the treatment. It collected detailed day-by-day self-reports of drug and alcohol use throughout the treatment period, as well as the 28 days before random assignment. The participants' self-reports of illegal drug use were verified through urine toxicology screens. Overall completion was 66%. Treatment was completed by 26 participants who received standard treatment only and by 22 participants who received the computer-based CBT. The participants assigned to computer training submitted significantly fewer urine specimens that were positive for any type of drug. The mean number of positive specimens for them was 2.2 compared to 4.3 for the patients who received standard treatment only. The proportion of positive urine samples was also lower for the group receiving the experimental treatment, 34% versus 53%. Our final article is by Christian Griot and colleagues. Increased anxiety during anticipation of unpredictable but not predictable aversive stimuli as a psychophysiologic marker of panic disorder. Previous research has shown that patients with panic disorder display normal fear responses when anticipating predictable threat. However, panic attacks typically are irregular and uncertain and are perceived as arising out of the blue. Heightened sensitivity to unpredictable aversive events among individuals who experience spontaneous panic attacks may, over time, lead to persistent anticipatory anxiety. This promotes the transition from panic attacks to full-blown panic disorder. Griot and colleagues studied 24 medication-free patients with panic disorder and 24 matched healthy subjects. Their physiological responses to being startled were estimated by measuring the movement of their eyelids when they received puffs of air on the forehead. This startle response was measured during 3 conditions, each of which lasted 150 seconds. One was a neutral period in which geometric shapes were presented. 6 puffs of air were administered, 3 during periods without the geometric cues, and 3 immediately following cues. In the other 2 conditions, unpleasant stimuli were presented periodically. In one of these conditions, the stimuli were preceded by the visual cues and were therefore predictable. The unpleasant stimuli were 4 different aversive sounds: white noise, a 2 kHz tone, a smoke alarm, and a female scream accompanied by a picture of a fearful woman. Both the patients and healthy subjects had greater startle responses in the condition with predictable aversive stimuli than in the neutral condition. When presented with unpredictable stimuli, however, the patients had an even larger startle response, while the healthy subjects' responses were somewhat smaller than their reactions to the predictable stimuli. The study does not identify the origin of this vulnerability to unpredictability in patients with panic disorder. It could be an innate trait or a response to repeated panic attacks. Therefore, it may provide a physiological characteristic that could be useful in future laboratory imaging or other studies of panic disorder. This possibility is the subject of the editorial by Walton Roth, Translational Research for Panic Disorder. He notes that the finding of a physiological marker of panic disorder would imply that we are dealing with a phenomenon that is greater than the patient's self-report. Although the hope of DSM anxiety disorder diagnoses has been to go beyond the patient's words to reach a classification or an assessment of severity based on biology, we still diagnosed anxiety disorder patients solely on the basis of what they tell us. If a physiologic marker reflected the type and severity of pathological anxiety, we could use it as a kind of lie detector to weed out malingerers or to detect individuals who are alexithymic and report that they are not anxious when they really are. However, Griot and colleagues do not claim to have such a marker. What the authors have accomplished is to go some distance beyond self-reporting by using startle as a measure of fear, one with somewhat different properties from the classical autonomic measures used by psychophysiologists such as heart rate and skin conductance. Startle could be applied to monitor the severity of anxiety and its change after either psychological or pharmacological interventions. Thus, this study is translational in that parallel experiments can be carried out in humans and animals. In animals, the fear circuits and neurochemistry of startle have been extensively charted, giving a depth of biological understanding that cannot be reached with human experimentation. Evidence has been found for a distinct neural system in phasic fear toward predictable shocks and in sustained anxiety toward unpredictable shocks. The former is based on the amygdala, and the latter is based on the bed nucleus of the stria terminalis. Do the design and results of this study give us something that would be useful in developing new treatments? The greatest hope of translation is to be able to apply findings at the molecular, physiological, or learning level in animals and humans to create better treatments for pathological human anxiety. However, recently developed effective therapies for panic disorder have emphasized changing patients' false thinking, one thing that cannot be translated between humans and animals. Although it is as hard to prove the validity of cognitive anxiety theories as it is to prove psychoanalytic theory, there is no doubt that therapies inspired by cognitive premises work. To integrate psychological and biological thinking has never been easy. Insofar as specific thoughts are the cause of panic disorder, pharmacological and anatomic localization of these thoughts is as unlikely to be useful as it would be to distinguish whether a person was thinking in French or in English. Learning paradigms that are analogous in animals and humans have been said to inspire new therapies. For example, Volpe's experiments in cats as a basis for systematic desensitization in human phobias. However, it is debatable whether animal learning experiments were scientifically necessary for developing current behavioral or non-cognitive interventions in anxiety disorders. Pharmacotherapies also benefit panic disorder, but in ways other than affecting learning and thinking. In this situation, translatable models take center stage. To develop new drugs for panic disorder, we need to know what neurons, with what chemical properties, and in what locations should be altered in order to design and select proper molecules. This is greatly helped by the availability of a feature of human panic that is translatable to the animal level. This is something that Griot and colleagues provide in this study. Knowing that patients are hypersensitive to unpredictable but not predictable threat provides clues for potential neural targets for drug development. For example, the activity of corticotropin-releasing hormone in the bed nucleus of the stria terminalis is believed to mediate sustained anxiety in response to unpredictable aversive events. Compounds that antagonize corticotropin-releasing hormone might someday be used to treat panic disorder. Full-scale clinical trials are expensive and time-consuming. Screening new compounds by using fear-potentiated startle in rodents and then applying the same paradigms to humans should help accelerate drug discovery. This concludes the audio highlights of the July issue of the American Journal of Psychiatry. We invite you to our website, ajp.psychiatryonline.org, for the full text of these and other articles. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Thank you.